Those will work. Okay. So just to give you an overview of what I'm going to be going through today, this is an acronym that I made up, and it doesn't mean anything. I think we have way too many acronyms in pharma as it is, so you don't need to remember this by any means. But what I wanted to do today is illustrate how we approach a problem and model-informed drug delivery. And this is definitely not our typical type of problem, at least that I encounter at Metrum Research Group. So this is a little bit different, but just by way of example and illustration, I'm going to kind of take you through this process of MIDD that we apply to these problems. And so first we establish the problem, which is usually an unmet clinical need. And then we frame the problem in a way that we can measure our progress, usually in the form of a quantitative question that we can answer with modeling and simulation. We then analyze the data that we have and understand the data. Ooh, it's going by itself. And then we report our findings and really scrutinize the model and declare our assumptions and what we would do to improve in the future. That is the process. So first we'll start with our problem. And our problem that I'll be talking today is this neonatal opioid withdrawal syndrome. And this is when infants are exposed in utero to opioids, and then they're born with undergoing withdrawal from opioids. So this is very sad, and the incidence has actually increased substantially, as you can imagine, in the setting of the opioid epidemic. I think it was hard to get recent data, and probably maybe some of you in the room would know this better than I do, actually, but I read that between 2016 and 2020, anywhere from 6 to 8.8 per every 1,000 neonatal hospitalizations within that period is the incidence rate. So that's definitely increased in the last 30 years. So the symptoms of this include just irritability, autonomic instability, poor feeding in these infants, and loose stool. About 1/3 of the infants with the syndrome can actually respond to behavioral approaches. So like low stimulus settings, turning the lights down, more frequent feedings and breastfeedings, rooming in, things like that, that can definitely improve or even cure the syndrome. But actually 2/3 require pharmacological intervention. So the standard of care right now, I think is usually morphine being administered for co-symptomatic control, and then the infant has to be weaned off. But the choice of the selection of the opioid is still under some debate. So the project objectives, so this is our problem, our objectives can be kind of seen in two kind of lights. On the left side is our modeling project objective, where we're going to use existing PK and PD models to validate and update recommendations for this buprenorphine starting dose, titration rate, and weaning rate. So these can be measured in these kind of benchmarks, where we'll start at an initial dose in these infants, and then they'll wean, titrate up. And so this time to stabilization is sort of this time that it takes to achieve this apex. And so they're stabilized on one dose for at least 2 days, and then they can wean. And so that's the time to wean, TTW. And then they can begin down titration. And then the total amount of time that they're on the buprenorphine is the time it takes to achieve drug cessation. And they can stop drug when they reach 10% of their initial dose. So this is our modeling objective. Our clinical objective is just basically to reduce that time from beginning to end, reduce hospital stays in infants with NOWS. Okay, so now we want to frame our problem in a quantitative question, or a way that we can measure progress. Our quantitative question is going to be what starting dose and titration rate is required to reach the target exposure and full stabilization in at least half of our subjects in less than 12 days. And this 12-day benchmark comes from our PD model that was developed, where if we didn't have any treatment at all on board, it took about 12 days for those infants the model derived was 12 days for the infants to reach stabilization. Also from that model, we found that our target exposure for stabilization was about 0.8 nanograms per mil. And this was the equivalent of an AUC of about 40 nanograms per mil in patients with moderately severe NAS. So now we want to analyze our data. So I'll talk about the data that we had available for modeling first. So I should mention this small part of the project that I worked on was part of a decade and a half of clinical research. So this has been going on for a long time. So starting out with 2 very small phase 1 studies that were published in 2008 and 2012. These data were used to inform this larger head-to-head B-born trial where they looked at buprenorphine and morphine head-to-head. And the dosing paradigm for this study was just empirically derived. We used a PK model that was developed in phase 1, but we didn't have a PD model yet. So they sort of gave it their best shot. They used a starting dose of about 16 microgram per kg. The response endpoint was this mother NAS score. And I'll talk a little bit more about what that is in a couple slides. But that's what we're going to use for our PD model ultimately. And then the outcome of this study was that buprenorphine reduced hospital stays on average by 12 days, which was pretty remarkable relative to morphine. So then when we had data from this study, that was used to build a PD model and then inform a dosing regimen for this smaller open label study called B4. And they indeed increased the dose. They found that starting dose looked like it was going to be advantageous. We looked at this mother NAS score again as a PD marker. And the outcome was, again, shortening the time of treatment to 18 days. That was a good outcome. So this is a similar slide. I just wanted to show how these data were used to inform the different models that were used. So again, the phase 1 study was used to inform the PK model. When we had this larger trial data available, we updated the PK model. And at that point, the PD model was developed, as well as the adaptive dose simulations. And those were used to inform the open label trial. And then when we had these data available, we again updated the PD model and evaluated the adaptive dose simulation. So we just continue this iterative process to inform future trials. Okay, so our pharmacokinetic model, I just wanted to show you sort of the key elements. So if you're not a math person, don't worry. So our clearance here is defined in addition to this allometric scaling term, which is something we normally do in all of our population models. We also have these maturation pieces where we have sort of this steep increase kind of characterized by this Emax function relative to postnatal age, which is measured in days. And then we have this exponential piece that's kind of the slower increase, whereby 23 days about postnatal age, the infant is about 100%, almost 100% of adult clearance. So that's how we sort of relate infant to adult clearance in the model. And then we do a similar thing with volume of distribution. Contrastly, volume increases much steeper, in a much more steeper way with this Emax kind of function. And the infant quickly arrives at adult volume much faster. So those are sort of the interesting pieces of that model. And then for this B-born trial, our dosing scheme again, I just kind of wanted to show how these sort of knobs that we can optimize with our adaptive dose simulation are sort of part of our dosing scheme here. So our starting dose, which was something we can optimize, was again 16 microgram per kg. And again, these were empirically derived. No, we hadn't had a model at this point in time yet. Our up titration rate in the study was 25%, every 8 hours they could go up a dose. There was a max number of up titrations, and then the wean rate was about 10% every 8 hours. And so this is our PD endpoint, this mother NAS scoring system. And this was based on the Finnegan neonatal abstinence syndrome score that was developed in the 70s. Getting ahead here. And then the name was derived from this larger clinical trial, but we borrowed the scoring system for these studies. But just to give you an idea of the things that they're looking at here and their scoring, so things like excess crying or length of sleep, autonomic nervous system items, muscle tone, fever, and failure to thrive, so body weight. So there's 19 elements, and they score these infants every 4 hours. So there's quite a lot involved with these clinical trials. But just to give you an idea, we're aiming for scores less than or equal to 8 to be able to wean the infants off the drug. So this is our dosing scheme for B-born, and this is pretty involved, but again, these are the key elements of the things that we'll use in our adaptive dose simulations. So when an infant has a sum of 3 Finnegan scores, so Finnegan scores, again, we mother NAS, we kind of use those interchangeably, or NAS scores. If they achieve a score greater or equal to 24, sum of 3, or the current score is greater than equal to 12, they can up titrate. If they do hit that maximum dose that we specified, they'll receive an adjunct therapy of phenobarbital. But if they can maintain stability for 2 days without dose advancement, then they can start that weaning process. A score of a previous 3 scores of less than 18 is required to wean, and then they can achieve cessation, again, if they're within 10% of that initial dose. And so with that B-born data, then we could derive this pharmacodynamics model. And the interesting kind of pieces with this are this kind of characterization of the underlying time course of withdrawal. And so that was kind of characterized by these first 2 equations where we have this negative drug K, which is the rate of removal of the xenobiotic, so the opioid that's in the system, the rate that it's going out. And then this NAS max is the max withdrawal symptoms. So these kind of combine in this differential equation to describe that time course. And then E is our drug effect, where we have the sigmoidal Emax relationship. And then that all describes the change in time of the NAS score. So then these were the results of the PD model, or the pharmacodynamics in B-born. They found that when we did this analysis, that clearance was the largest source of variability, which is kind of intuitive. We know that clearance was related to postnatal age, so that will change subject to subject. Time to stability also increased with clearance, which also is kind of intuitive. So for higher exposures, you'll have a faster stabilization time. And then this is where they got that kind of target predicted stabilization time of 0.8. So when we looked at quantiles of exposure, and we sort of did this survival analysis, we found that the fastest quantile to achieve stability was around this 0.8 nanogram per mil. So I just wanted to show where that was derived. But favorable results for B-born. And then so in comparison, our next trial, B4, we again leveraged this information from B-born to sort of increase or change some of these parameters, these knobs. So our initial dose was increased from about 5.3 to 8 microgram per kg in that study. We increased the up titration rate by a little bit, 33%. The maximum daily dose was increased, as well as the weaning rate. So the weaning rate was increased from 10% to 15%. in hopes to lengthen the duration of hospital stays in that study. So this was the before dosing scheme, and this was very similar to newborn. Same kind of criteria had to be reached in order to be able to uptitrate or wean. And then again, drug cessation can occur when the final dose was within 10% of the initial dose. Infants can also receive phenobarbital or clonidine if that maximum dose was reached before stabilization. And at the time we had before data, we updated the PD model, and the structure stayed very similar to the previous structure. We actually simplified the time course of withdrawal a little bit. So we have one equation now that describes that. And we simplified our drug effect a little bit as well. And then these are the parameter estimates that came out of that model. So now for the fun part. We did these adaptive dose simulations in MRG-Solve, which many of you have heard of, I think. It's an open source package in R that was developed at Metrum. And it's on CRAN, so it's publicly available. And so some advantages of using this package over non-mem is one being that in non-mem, every time we want to change one of our dosing paradigm parameters like titration or wean rate or starting dose, we would need to develop a new control stream or a new data set. But with MRG-Solve, we can actually do it in one line and just change the parameterization. So it's way easier to make it adaptable. Probably the most important aspect of MRG-Solve is being able to more adequately represent the simulations. So we can, in real time, kind of compute that rolling sum of the Finnegan scores that are required for the uptitration or the weaning. Really important aspect. Okay, so if coding is not your thing, don't panic. So I'm just gonna really high level go through what we're doing here for these adaptive dose simulations. But this is a header file. And what this kind of allows us to do is leverage functions in C++ to be able to pull into MRG-Solve, which we use R for. So what we can, and this really allows us to compute that rolling sum that I talked about. So first we declare like a class of variables. And C++ requires that you declare the type of every variable that you use. So that's what's going on in this block, top left. Below that, we have a reset function. So for every new subject in our data set, we're gonna start over and start computing that rolling sum de novo. And then we have on the right, we have our kind of summing functionality where we're computing every 3 records, we're adding that Finnegan score, or their NAS score. And then that final kind of block just keeps track, just keeps that vector of 3 rolling for every line in our data set. So then when we look at our model file, all we need to do is simply include our header file in that include block up at the top. And then in the global block, we pull in our functions and we give them this sort of object name of hx. So then what we can do is we can just use this hx suffix and then be able to pull every function from that header file. So in the main block, we're resetting, again, for every individual. We want to compute a new set of PD endpoints. And then we use the rest of our model normally, and then we can capture that rolling sum with this hx sum call and output that in our data set. And then I just wanted to give you, this isn't the whole length of our simulation code, but just an example of how we implement our dosing paradigm. So we have the rules for titration, again, are this. Rolling sum has to be greater or equal to 24, or a single score greater than or equal to 12. And then we can titrate. We want to keep track of the number of titrations because that's also a rule in our dosing scheme. And then below, similar for weaning, if a single score is less than or equal to 8, or the rolling score is less than 18, then we can begin to wean. And then we use these sort of D-type and EVID flag variables to kind of keep track of our dosing events. And then we sort of do some housekeeping with this EVID flag of 105. Then we capture, for every line in our data set, our rolling sum of our Finnegan scores. That is the code. So now we can report our findings of our simulations, the results, what we've learned, and sort of scrutinize our model and see where we sort of fell short or where we would do different in the future. So when we have our simulation code in place, we can kind of create these survival curves or these Kaplan-Meier curves. And if you recall, the simulation question that we're trying to answer asks, what starting dose and what titration rate do we need to achieve stabilization in at least 50% of our population in less than 12 days? So we have this curve, and we can kind of draw this cut line across that there's 50% probability. And we see here that, at least in terms of time to stabilize, that the starting dose really doesn't make that much of a difference. They're kind of all collapsed on top of each other. So regardless of starting dose, we can achieve stabilization in anywhere from 2 to 4 days, or so our model predicts. That was one finding. In contrast, if you look at weaning rate, the starting dose actually does make a big impact in our predictions of our time to wean. So for example, we're looking across that 50%. If we have a starting dose of 1 microgram per kg versus a starting dose of 5.3, that can make a difference of about 2 days for time to wean. That actually does make a big difference. So we can do this for every sort of parameter in our dosing paradigm, and we can kind of create this summary table where we can find our sweet spot for our optimized dose parameters. So as we increase our starting dose, sort of on the left here, and kind of change our titration rate or our wean rate across from going from left to right on the top, we can see, as our kind of Kaplan-Meier curve showed, that increasing our dose didn't really have a big impact in our time to stabilization. So that's kind of shown here in these predictions. If we look at time to wean, however, if we kind of look at a dose of 8 microgram per kg, for example, we do get large gains in terms of weaning rate. This is like our graph kind of showed. So we go from like 8 days to wean for a 1 microgram kg to about 6 for 5.3, and again that decreases to about 5, closer to 5 for 8 microgram per kg starting dose. We do see that increasing titration rate doesn't bias a whole lot, though, in terms of either time to stabilization or time to wean. We're probably staying where we were in B-born at that 25% titration rate is probably where we want to stay. If we look at time to cessation, and just look, for example, at the 8 microgram per kg dose, going from left to right, we see that we can actually decrease our time to cessation by 2 days if we increase our wean rate every 5% increment. So going from 12 to 10 to 8 is what our simulation kind of predicts. So if we compare the results of our simulation to what was observed, we actually found that our simulation was much more optimistic than what we observed in the B-born trial. So for example, for a starting dose of 5.3 at 25% titration rate, our model thought that we could achieve stabilization in about 3 days. In reality, it was about 4.9. So I'll talk about reasons why we think that is. So kind of end of story is that our optimized parameters, again, we probably want to start a little higher. We think we probably had that right for the B4 study. A starting dose of about 8 microgram per kg was really beneficial for those infants. We could probably stay at a titration rate between 25 and 30, and that was kind of our sweet spot from our simulations. We could increase the wean rate, however, to probably between 15 to 25% to see those decreases in hospitalization times. So kind of an interesting finding from our final PD model was that our estimated EC50 was about 0.9, which was a little bit higher than our previous models indicated. The average concentration in those studies was about 0.26, which kind of shows us that we're at the low end of that exposure response curve. So we definitely could have some benefits from dosing higher. But again, we kind of want to use a conservative approach, keep an eye on our safety endpoints, so that we're not overdosing these newborns that wouldn't benefit from higher doses. So we want to talk about some reasons why our simulations might have been different than what we observed in these studies. So a number of reasons why that could be. One of them is just that simulation is not real life. There were protocol deviations that could have happened at the discretion of the attending clinician. Probably the biggest reason for the differences that we saw were that we didn't impose this maximum dose rule in our simulations. So at the time an infant achieved that maximum dose and couldn't stabilize at that point, they received adjuvant therapies. And we don't have PD models of those, so we couldn't really accurately simulate that scenario. So we just kind of ignored it in these simulations. But actually, if we do the simulations and if we just censor those individuals that reach the maximum dose, then our simulations were a lot closer to observed in terms of time to stabilization. On the subject of adjuvant therapies, actually 50% of the subjects in B4 reached that maximum dose and had to receive an adjuvant therapy. We think those infants just had more severe NAS or NOWS and needed that rescue. So that was a big chunk of our data that we're just like censored that we weren't able to use. So that was a little bit unfortunate situation for our simulations. And finally, a difference from what was reality versus our simulations were that this titration event rule, where in reality they could only titrate once a day, and we didn't impose that in the simulations actually. Okay. So for future work, there's still a lot of work to be done. So trainees, if you need if you need another project, there's a lot of work out there still left to be done. Probably the lowest hanging fruit would just be to assess these shorter dosing intervals in our simulations. So currently they dose every 8 hours. We might look at dosing in shorter intervals. We'd like to develop parent metabolite models for buprenorphine. So this will help us sort of decrease the uncertainty in our parent PK parameters, and also maybe make a case for being able to dose in younger infants if we can characterize this glucuronated buprenorphine in urine. We would like to characterize our adjuvant therapies and the potential drug-drug interactions that are at play to be able to closely mimic what's going on in reality. And finally, there's opportunities, obviously, for real-time simulations where we can just leverage inter-individual variability, and each regimen could be individually tailored for those infants, which would be really powerful if we could figure out a way to do that. Okay, so just in review of what we talked about today, we have our clinical unmet need of NOWS. We talked about how we measured it and we modeled in our PK/PD model. We framed the problem in a way that we can measure our progress and in a quantitative question. We analyzed the data, we modeled it with PK and PD. We developed that adapted dose simulation and we optimized our dosing parameters. And then we reported what we learned And we talked about why our simulations might not be totally aligned with what we saw in our clinical results. So that is all I have for you today. I just want to say thank you to Dr. Walter Kraft, who was the attending physician for all of these studies, lead clinician. And he's had a long-term collaboration with Dr. Mark Gastingay, so that was why I had the opportunity to work on it. So I was really grateful for that collaboration that's been going on for a long time. Dr. Ana Ruiz was who oversaw the project at the time that I worked on it, so I was grateful to her. She helped me through some of the modeling and simulation. And I wanted to include this QR code or this link also for you. MRG Solve is being actively developed and actually hot off the press. The last iteration of MRG Solve that's on CRAN right now has some of these built-in adaptive dosing functions. So that kind of absolves the need for that header file. So if this is something that you need to do or that you're just interested in, this is really worth checking out. Yeah, at this time, I'd be happy to answer any questions that you have.
Thank you for that presentation. That was really clean and really exciting for me because I work over at Riley and I know that we have a lot of these patients that need this type of treatment. One of the non-pharmacological treatments for this disease state that I know of is like physical like comfort, like holding the babies, rocking them, making sure that they feel like comforted, basically. Like that seems to have a really high impact on them. Is there like a way that you could incorporate that into a model, or is that like not a thing?
That's a good question. I think if we could score it sort of in an objective way, sort of similar to the way we do those NAS scores, we could probably incorporate that. But yeah, I was reading about that actually as I was developing the background for this, and I was like, oh, I wanna hold some newborns. I'll volunteer to do that. But yeah, it's remarkable how much of a difference that makes.
Yeah, I wonder if like, I don't know, if you could incorporate that like as a covariate and see like if that impacts like the way that they respond to the medication too, because it can probably like really enhance it.
Yeah, definitely. As long as we can measure it objectively.
Yeah.
I don't see why not.
Thank you.
Yeah.
Thank you, Rena. It was a spectacular talk. Very, very, very interesting. By the way, answering her question, yeah, it's possible as soon as they are recording exactly when they were doing it. So if it's recorded, yeah, it's possible. So I have a naive question and also a comment. So the naive question is, for the maturation function, did you try to also explore if there is any difference between the gestational age or the postnatal age? Because sometimes, you know, they are not full-term babies. So I'm wondering if there is a difference in the maturation function. And then the comment is regarding non-men and MRG Solve. You know, I love MRG Solve. I love it. I love it. But at the same time, it's true that there is also possible to do it with non-men.
Yeah.
So you have to include all the possible documents in your data set. And then in your model, you can control with F if it's going to be a dose and how much, no? So it's possible.
Yeah, thank you. Thank you for
but
that.
I love MRG Solve.
Thank you for that vote. Yeah, as far as I know, they didn't look at gestational age versus PNA, but that is a good point. We've done some research in the past that have shown that there are maturation differences. That would be an interesting thing to look at. Thank you.
Thanks for the great presentation. Really enjoyed it. Quick question. In the very beginning of your presentation, you mentioned that 0.8 nanogram per milliliter is the target exposure concentration. What PD marker was that based on? Was it Finnegan score or did you use any other? Because most of the times it is so difficult to diagnose NOWS, like whether the baby is sleeping too much because of NOWS. I mean, I just wanted to see how quantitatively that was connected to efficacy.
Yeah, so as far as I know, it was directly derived from the NAS score. So yeah, so they just kind of drew these survival curves and separated it by quantile and saw that the fastest group, that was the average exposure in that fastest group that obtained. Yeah. Sorry, yeah, those are all like decades of models that have been changed and morphed, and so those terms just sort of get carried along. But yeah, NAS Finnegan score, yeah.
Hi, I'm Matangi from University of Maryland. Great talk. I've been working in this area, and I mean, our group used the morphine part of the B-bond trial for one of our projects. So it was nice to see the the buprenorphine part of it. My question is like, so these two trials did measure levels of buprenorphine, right? But in regular clinical care, it's the measure, I mean, nobody takes concentrations, only the symptoms are measured. So how do you think the model that you have developed could be translatable in real clinical care settings where there are no concentrations, it's just the symptoms or the Finnegan scores would be the one that will be available and the doses?
Yeah, I mean, here they did pull those samples. They were probably pretty sparse, but that was why it was so important to have the PK model in place from prior trials. And I think that's part of the reason why Dr. Kraft is pushing for that glucuranated urine data, so that way it's not as invasive. We can kind of leverage that data and pull that into the PK part. That way we already have the PK, we know what that is, and that can be just be predict. Not ideal. Like we would still love to have PK, but yeah, that's reality, right? we can't have everything that we want.
So if I can ask questions regarding your covariates for your clearance and volume, there's a weight as a covariate, and question I have is that a weight at birth or is it a current weight all over the time of measuring the concentrations?
That is probably the baseline weight.
Okay.
Maybe the weight for it.
So, oh, I see. Okay, so well, if it is just the birth weight, then that's fine. So otherwise, that would be a quite a interesting covariate because it changes, right?
Yeah.
Okay.
Yeah, I'd have to double check on that because that's a good point. In this population, usually a baseline weight is good enough, but yeah, for this population, we probably would want a time varying covariate there. I don't know that we did for these simulations because I think there's so many combinations of parameters here. We might have just picked a range and kind of did the simulation from there. But yeah, that's a good point. We could definitely try more within that range where I showed with the weaning, where it makes a big difference with the wean score. We could definitely try to fill in that white space. Yeah, that's true.
Great talk. When you determine your target concentration, did you take into account some of the metabolites, particularly the NOR1, which is also pharmacologically active, probably, as you know? Is that important in that the exposure is great in that type of population?
Yeah, that was modeled, the buprenorphine. I think they just sort of determined that the driver of that PD endpoint was the parent molecule. So I don't know if that was used to derive that target exposure. I don't think it was. I think they just sort of looked at that parent and the PD endpoint, drive that. But they did model that in the publication for the PD model. That's part of that. So if you're interested in that, yeah, please look at that paper.
We have time for one more question only.
Awesome.
Thank you very much for the great presentation.
Thank
So
you.
we are out of time. The next